Good afternoon, everyone. I would like to thank the organizers for this opportunity. After Sir's talk, everything is going to be a little difficult convincing people for ALND in the era of when less is more. I'm trying my best. So I am Dr. Lohita Krishna. I'm a consultant orthoplastic breast surgeon at Sri Shankara Cancer Hospital, Bangalore. So why is axillary surgery so important? It plays a very important role in staging. It gives us prognostic information. It gives us local disease control. Axillary management is becoming more and more complex nowadays. So there was this era when post NACT, every patient would undergo axillary lymph node dissection. Then we thought, should we do sentinel lymph node biopsy prior to neoadjuvant chemotherapy? And then it was clear, if the sentinel lymph node is positive, go for ALND post NACT. If it is negative, no. Then we are now in the era where we are evaluating them into two different groups, clinically N0 at diagnosis and node positive at diagnosis. What's happening in neoadjuvant chemotherapy is what we see, what we want to see is downstaging of disease in breast and axilla. We will see an in vivo response and there are higher chances of attaining PCR, and PCR has shown to give us a better disease-free survival. Is tumor size related to the axillary lymph node metastasis? The association? Yes. So as the tumor size increases, your chances of axillary lymph node involvement also increases. Now, is the breast PCR equal to nodal PCR? No. What radiological and pathological response in the breast and axilla are completely different, and they should be viewed as two separate entities. Responses are vary according to biologies. Hormone positives have very partial response to neoadjuvant chemotherapy, whereas triple negatives and HER2 positive diseases have better chances of attaining a pathological complete response. Now, this also varies between breast and nodes. So there are three scenarios here. Clinically, node 0 at diagnosis, then comes our N1 and then N2. One advantage which we have with breast is the lymphatic drainage is in a very orderly pattern, unlike head and neck cancers. So when we do sentinel lymph node biopsy before NACT, it gives us an accurate staging. It identifies patients who can avoid ALND if sentinel is negative. It identifies patients who need radiation therapy. The only disadvantages are it requires two separate surgeries. If there is a delay in wound healing, that delays your start of neoadjuvant chemotherapy. And importantly, it denies the opportunity of being spared ALND post NACT. That is the main reason why now everyone talks about doing SLNB post neoadjuvant chemotherapy. Now, what are the concerns when we do this after neoadjuvant chemotherapy? So neoadjuvant chemotherapy causes fibrosis and scarring of the lymphatic channels. That decreases our identification rate, and there is non-uniform effect of the chemotherapy. So now you have a node which has disease, and the lymphatics have become scleroid and necrosis. Now that is no more your draining lymph node, and when you do a sentinel lymph node, you're going to pick up another node. So this will cause a higher false negative rate. The main concern here is clinically node positive patients who have now turned clinically node negative. Can we consider SLNB in this group of patients? So very recent meta-analysis, just few months, it considered 79 studies. It included 10,680 patients, and it showed false negative rates are still high, 11.8. Only below 10 is acceptable. And when we go deeper, it shows that hormone receptor negative and HER2 positive patients had more false negative rate compared to other groups. And this also shows that 26.8% of patients with initial clinical node negative status had nodal metastasis after NACT. Now another paper from Tata. Now I'm going to concentrate a few on the Indian studies. There are very few, but yes, this is an Indian study. And they looked at around 750 patients, and the clinical T size to start with was T2 and T3 in majority of the cases. These cases have turned node negative post NACT. And when they did that, The first group, what you can see is your sentinel node group. That is your true sentinel. They used a dual tracer, hot node, and a blue node is identified. Sentinel node plus adjacent palpable lymph nodes. What they did is they identified the blue node, they identified the hot node, and adjacently wherever there was a palpable node, they've even picked that and sent. The other one is your low axillary sampling. Now the mean lymph nodes retrieved in sentinel lymph node biopsy, true sentinel lymph node biopsy group was 2, sentinel plus adjacent lymph nodes were 5, and low axillary was 7. And the true sentinel nodes showed a false negative rate of 31.6%, which is completely not acceptable. And when adjacent nodes, that is, you can take it as a mean, then 5 lymph nodes removed, and yet our sentinel rates were 19.7. Then you have another study from Kidwai Hospital, which looked at 44 locally advanced breast cancers. Of this, 86% were clinically node negative, positive to start with, and they've all turned negative post chemotherapy. In this study, clinical examination and ultrasound of the axilla was used post NACT. Overall identification rate was 86.4 and false negative rate again 21.4. Now, this group also, these are the majority of the cases in India where we give NACT. So, again in India, primary surgery is considered for very early breast cancers. Primary surgery is preferred for hormone positive cancers also. Now, the gray area here will be your TNBCs and HER2 positives, where a multidisciplinary approach is advised. We need to do triple assessment of the lymph nodes. Pathologically also, FNAC or biopsy has to be done to determine the clinical status pre-NACT and then go forward. Even in clinically known negative patients, there was high rate of subclinical involvement of the axilla in the NSABP P18 if we look at it carefully. So the recommendations are to consider sentinel lymph node micrometastasis or ITCs also post NACTs as node positive disease irrespective of the biology, as this low disease burden also indicates non-uniform effect of chemotherapy and also chemo-resistant diseases. Many a times we get calls from a pathologist, frozen section, they say it is negative, and then the final pathology comes, oh, there are multiple, there are some micrometastasis on deeper section. Now, what is the mode of evaluation in this residual nodal diseases? So, clinical examination, axillary ultrasound, which is most commonly used, and the sentinel lymph node. Axillary ultrasound has accuracy of only 62%. Now, use of axillary ultrasound in predicting chemotherapy, is it a good predictor? There was a study which included 402 patients who were clinically node negative. They did a pre-NACT as well as post. 54% of the patients with abnormal lymph nodes on imaging pre-NACT did not require ALND post NACT, and 20% of patients with normal looking lymph nodes on imaging pre-NACT had diseased lymph nodes post NACT. So this study concluded that axillary imaging pre-NACT is not accurate in predicting nodal metastasis and need for post ALND post treatment also. Then you have the MRI, of course, by not mentioning it. The sensitivity okay, but the specificity rates vary a lot amongst literature. For targeted axillary lymph node dissection, it has opened more questions and left many questions unanswered. So locating and removing both clipped nodes and sentinel nodes is what targeted axillary dissection is. Yes, results have shown decrease in false negative rates, but we still do not have an ideal tool for this targeted axillary dissection. Many markers can be used. You have radioactive seeds, you have MAC seeds, you have carbon tattooings also. We really don't know which one to use. Then how many nodes have to be placed? Is it in one or is it in many or all suspicious forms? Then what if the clip is lost? Then can all the clips be retrieved? No. Many studies have shown that 20% of the cases the clips are not retrieved and you have to revert back to your axillary lymph node dissection. And the use of this, whether it is to be used in clinically node negatives or node positives, that also we need answers. Arm lymphedema, yes, we do acknowledge that ALND has increased breast cancer related arm lymphedema. But now with immediate lymphatic reconstruction coming up, maybe we can decrease those rates. Now, trends in axillary management of early breast cancers. This was a questionnaire then published in India. So this included, the questionnaire was answered by 111 doctors, and they said that 47% used methylene dye alone till date, and the other 45 doctors did not perform sentinel lymph node biopsy. This is in a general sentinel lymph node biopsy, not like post NACT. And the reasons for not performing is radioactive dye not available, frozen section not available. The other reasons are lack of training, financial issues also. So in India, it has to be still, like even in 2-tier cities also, people need to have sentinel lymph node biopsy availability. So why not? So majority are retrospective studies. What we are looking at, prospectives are very small series. Survivals also still very short follow-up, long-term follow-ups are required. Our stages of presentation is completely different from what we see in the Western world. We have more T2s and T3s. Dual tracer, again, as I told, licensing, availability, and cost. Then with us, patient follow-up is also going to be a little poor. Now, when we come to the 2021 consensus statement from the Association of Breast Surgeons of India, I read as they say, in post-NACT setting, targeted axillary dissection or picking of clip node is an ideal option to decrease the false negative rates and should be done in context to research settings. In clinically node positive, which have become clinical node negative on imaging after sentinel lymph node biopsy, SLNB is not recommended. So by giving you a summary of all this, there is a growing evidence of omitting complete axillary dissection, but we need more evidences. Even though response is good with triple negatives and HER2/neu positives, given the aggressive nature of these tumors, leaving behind even micrometastasis in axilla will increase risk of relapse. It is important for institutes to recognize their own false negative rates and identification rates. Thank you.